today I'm in conversation with Linda Gask. Linda is a semi-retired academic psychiatrist and author of the book The Other Side of Silence, a psychiatrist's memoir of depression. Hi, Linda, and welcome to the series. Hello.
Hi.
Thanks so much for joining us. And perhaps you could tell us a little bit about why speaking in this series is important to you.
I've had a strong feeling we have to try and do something about the stigma that people who work in mental health care actually experience when they want to come forward and talk about their own mental health care. I've spoken to so many people who tell me, I don't know how you manage to speak out. And I would say, well, it is easier for me now that I've retired, but I've noticed there has been a growing trend of people who are willing to talk out while they're still working. And I was always fairly open about my mental health, even while I was at work. I just think it's extraordinary that we spend all of our time talking about the stigma that patients and service users experience, and then we stigmatise ourselves and each other. So for me, that's just crucial, really.
Absolutely. And it seems to be... Yes, it does. It completely makes sense. And it seems to be a paradox right at the heart of what I also found so difficult after I broke down, in that why should I suddenly be feeling these extra layers of shame on top of what can be difficult around mental health stigma for anybody anyway. And it was something about being a provider of mental health services. And you've talked a bit about your own identity and what you do as work and being a doctor and the story of that.
Yeah, I think something to do, particularly with medicine. I don't know if it's the same for psychology, but I think for medicine, and perhaps to some degree for nursing as well, it traditionally is a vocation. And it's something that from an early age, you take on this persona of someone who has to be able to do things. You have to be able to cope, and you have to be strong and not let other people down. But it becomes part of you, this is do the right thing and to care for others. And it's quite difficult when I think a number of people find it difficult when they kind of step away from that. And I certainly found that a little hard, because I think the thing in my whole career that I probably feel was the most valuable was the individual work I did with my patients, not necessarily my academic work, because that was working with individuals, and it's difficult sometimes to separate those stories. When I set out to write the book, I started off writing as a hobby, and then I started writing memoir. And I thought, well, I'll do writing about my own professional life. And it was impossible to separate the story of me from the story of my patients. Really quite difficult, because I identified quite a lot with the people that I've worked with. I've had a number of the same experiences because I've had problems with mental health throughout my training. And so life, you have these little stories, and it's quite hard to sometimes separate out a story about yourself from things that you've experienced with patients. So at least that's what I found. I know that a number of writers, doctors who've written have written stories about. I found it quite hard to talk without talking about stories about their patients. And that's something, even in the second book I've just finished, but now it's often people that I meet and people that I talk to. It's kind of hard from that desire to want to know about people. I think that's part of who you are as a doctor. You do know people, you know what makes them tick. Certainly that's what I'm interested. I'm fascinated by people's stories and their lives.
And I think there's something there about it does. It does. It's something about a really strong identity and a vocation, like you were saying. And then before we were talking about this kind of set of paradox, I'm going to call it for now. And how can we be alongside the lives of our patients, you know, or our service users, or the people we see as clients, you know, all the different languages that we come across in services. And also we have our own lives and our own identity too. And then sometimes we have similar experiences, you know, how do we work alongside that?
I think learning all of the supervision I had in my psychotherapy training helped enormously, because I learned about the importance of boundaries. And when I mean boundaries, I don't mean it in a way that's kind of trying to keep patients out. It's more trying not to let me become too much of what we're doing. It's really important not to identify too much with people. And I think for me, not assume that if a person was having difficulties in their life, then I could understand because I've been there before and this happened to me. Yeah. And I think it's very easy to fall into those traps when you've had your own mental health problems, you know. I can understand why they might be feeling depressed because they're a bit like me. And it's really, I think the power of supervision, good supervision, is it helps you to separate what's you from what's going on with the patient. And I'm unapologetic really. I'm a doctor and I've had patients, and for me that word kind of summarises the sense of responsibility I have for people, that I had to care, I had to do things, and that was part of my role in life. I know some people don't like that word, but that's very much, I guess, the way I did it, that I carried that burden for people. They were recovering. But it's very easy to identify too much. So I think you have to be able to separate. And people, you know, I understand. I can see that you have felt depressed because of the kind of questions that you're asking me. You understand what this is like, and what helped you. And I'd say, well, we can talk about that, but I'd much prefer if we use the time we have together actually thinking about what will do and what will be right for you based on what you've told me today, and really make sure that it wasn't about me. And I think that's just really crucial, that when you work with people, it isn't about you, but that doesn't stop you identifying with them very, very powerfully.
Yes, and I guess when you were talking about your psychotherapy, I was thinking about my psychotherapy and thinking about how helpful that has absolutely been throughout my training. I mean, I didn't go into it because I was becoming a clinical psychologist. I went into it because I needed help with something. But it's very, you know, it's been long term. And one of the things it did help me do when I was also being a clinical psychologist or in training was to gain a sense of understanding of, you know, what was mine and what was the other, you know, where the projections can happen, because we're working with such emotive stuff. And we are all humans. And I think psychotherapy has a lovely way of kind of embracing the fact that, of course you bring your own stuff. It's not a terrible mistake to have yourself impacted on kind of by the work that you're doing. So it's about how you then just work with that. I feel like, you know, you have a similar point there. You mentioned something when we were talking before about the importance of having other things outside of work.
Yeah, I think it's so easy. It's so easy in many different kinds of work. I think can be a particular problem for doctors, but I think I've seen it with other mental health professionals as well, where you begin to get everything you think you need from your work. it gives you what you need. And people talk about withers, and I think there is something in that. When you've had difficult things in your life go on, as I had in my earlier life, I had a tremendous sense of satisfaction from my work, and my work became too overwhelming. I had other interests and other things I was good at, like most medical students do. Famously, when you interview kids in medical school, they'll say, they do piano to grade 8 and Edinburgh's Gold Award and all sorts of things. It's a very sort of competitive environment. But I had other interests. I had other things I was good at. But throughout my career, they gradually kind of fell away. And when you become an academic medic, and an academic of any sort, it's quite hard sometimes to keep that bit of you that's not just working. And senior academic in a medical school, I was working 7 days a week, writing papers as well as doing my clinical work. And part of sort of recovering fully from depression for me, as I've been working at since I retired, I worked at it in a way during the periods when I was off work, when I was unwell as a doctor. But it's about rediscovering those things about yourself that are important, and the things you can enjoy, the things that are important. A bit like in CBT, but probably more than that. It's really thinking about how do you want, what are the things in life that really matter to you? And that's what I've been trying to rediscover again, partly through writing. Your life can get far too narrow. And I think a lot of us who experience depression, who work in professional jobs, particularly in mental health, I think we can get far too focused on being about mental health, and finding it kind of hard to have fun and escape and do other things that are interesting.
Yeah, that seems important to kind of retain that balance, especially when work can be so all-encompassing, or can feel so all-encompassing, and certainly working hours like that. I kind of defy anybody to retain a balance if that's the case.
It's really hard. It's really hard. I mean, I think it's particularly hard for women with children. I didn't have children, but I think it's even harder for them. Unless they're fortunate enough to have full-time carers, but I made that decision that to do. But it is one of those things that I think makes it particularly harder for women to advance as well. Yeah. If you want to do well in clinical academia, you have to write, and that's what I spent my life doing.
Goodness. It's a lot of pressure, isn't it?
It is.
But just thinking about that, and thinking about kind of pressure and systems, and thinking about kind of the systems around us that we work in and how they can sometimes influence, in a negative way, our mental health. And thinking about kind of the NHS and healthcare systems and mental health services as employers, I guess. I didn't know if you had any thoughts on that.
I don't think the NHS is a good employer. I'll be quite blunt about that. The university was a better employer when I was younger, but the NHS was... Again, it was those remarkable paradoxes that you work for a mental health trust, and yet they have absolutely no sympathy for people who work for them who have mental health problems. On one occasion, one of the first times I was really, really unwell for several months. I came in. Someone gave me when I was fit to go out, I came into the office to pick up one or two bits and pieces. And I got a letter from the personnel manager saying that he was pleased to see that I was well enough to come in. So he was looking forward to me returning to work. And that was just ridiculous pressure, and just remarkable, considering we spend all of our time saying, they look well, but they're not, they don't feel it. And I didn't even look well. I probably didn't look completely exhausted because I had been off for about 3 months at that point. But I've looked after many doctors and nurses in my career, and I've experienced similar things. Even, I think it would happen now, but even in the past, people trying to find out about patients who were nurses by going via the nursing hierarchy to ask questions in another hospital. Extraordinary things happening.
Oh my goodness.
So that wouldn't happen now, I don't think. I'm pretty sure it wouldn't, but it's still really difficult for people. I think there's a lot of words said about the understanding, we understand about your mental health, but when it actually comes down to it, doing things like a staged return to work can be very difficult. There is an assumption that you be what to work from the moment that you are well enough to work, and you will be well enough to do your job exactly as before, when actually what you need is a gradual return to work, maybe working part-time.
Yes.
There's an awful lot of wasted talent of people who have been off sick and could work if they were given the right kind of job, and a lot of vacant posts which are unfilled in the NHS, and people who could do them, but if only they could do them in a slightly more flexible way. So I think you think how much it costs to travel. It costs an enormous amount of money. And then there are people who can't actually work in the organisation because it's not flexible enough to be able to support people back to work. Well, it's something I'm quite angry about, really.
I agree with you on that.
A long-standing issue for me.
You're not alone in a cohort of people who really have a lot to say about what I call like the internal agencies of the systems that we work in, the occupational health, HR. There's some really, really good practice. There's great people. It's not, we're not kind of taking a broad brush on this. However, there is also some very poor practice. There's less understanding of exactly what you were talking about, the nuances of returning to work, and what that might mean. From my viewpoint, I've been trained and taught to use formulation as a basis for working. So I would map out in that way somebody's needs, for example, and their strengths and what was going on and what they can do and what they might want to work towards. There's no sense of seeing that kind of, say, formulation-based process. And then there will be other processes that do that, not just formulation, but, for example, speaking just from what I know, in terms of mapping out somebody's re-engagement with work. So somebody else in the series talked about a really excellent example of what she called a therapeutic return to work, which just doesn't seem like it's a norm, but sounded like an absolutely fantastic way of compassionately understanding that.
Yeah, it may have changed because I have been out of it for a few years, but I don't think it's changed from what I hear from people. So I suspect that's the exception rather than the rule.
Yeah, it's unfortunate. I think it's going to have a big
corporate structure. Yeah.
I agree. What I'm noticing is I'm kind of interrupting you a bit. I'm sorry about that. It's partly the connection, but also you've hit on a pretty hot topic there, and kind of thinking about the position of wellbeing strategies that are out there at the moment, and actually how far they really go, and do they step through the door of looking actually about what it's like to be, for want of a better word, inside a patient, really, what happens to those people who break down on the inside, and what's their experience, because we talk about the patient journey, and we hope to snag that, and we also need to improve that loads, more collaboration centrally. But we also, do we think about the quality of the journey for staff who are moving through these internal agencies as such? No, I don't think we do. There's not a sense of importing that knowledge on the inside.
Yeah. Sure. I mean, the way in which junior doctors are recruited and expected to suddenly move around the country at a month's notice or so, when they may have, families and partners, is just inhuman. And that's the way the system is set up. And then they wonder why people have mental health problems, or say that they're going to have a year out. It's hardly surprising, because the pressure is relentless, and it's a very inhuman kind of pressure.
It's amazing. The shadow side of the healthcare system can be rather large.
Yeah, it is.
I wondered if you wanted to say a bit more about how we think about having a long-term awareness when we've had experience of mental health difficulties and we want to try and sustain a career, despite sometimes all of these kind of more corporate things that feel like a bit of an obstacle. I wondered if you wanted to say a little bit about that.
I think for me, it's always been about finding a niche where you can feel comfortable. I first started having problems with anxiety when I was at school, so this goes back a long way for me. And severe anxiety as a medical student, and got quite depressed, and that was when I first saw a psychiatrist. Contacted the psychiatrist I saw and asked if he thought it was a good idea for me to do psychiatry, and he said yes, because I thought I wouldn't be able to do it. And I've encouraged other students in the same way when they've come up to talk to me at meetings. But so I've been aware, career, I guess, early on, that I was going to have episodes when things weren't as good, and it was about trying to find the right way of living in order to cope with that, which has sometimes been extremely hard, because describing the way that I've had to work, you have to find ways to cope with that, and it's hard. But I was lucky, because I was able to find that working partly in academia and partly for the NHS was where I felt happiest. And I was also able, because I was an academic, to pursue a particular career in primary care psychiatry, which would be harder if I was in a full-time NHS post. So I was able to find my way to somewhere that was right for me, or as right as it could be. And that's what I've usually encouraged people to do, is to try and look for that place, because my profession in medicine, never mind psychiatry, is very broad, and you can usually try and find something that you can cope with. You don't have to be with people. You can work full-time in a lab if you don't want to be with people. And I always enjoyed listening to their stories. It's strange, now I've retired, I don't see many, but I spent my life listening to people. And so I think it's about finding that. For me, it's about finding that place, but also finding ways of coping. I had a lot of psychotherapy, and I think that helped me immensely. I've taken a lot of medication, and I think that's helped me as well. I don't think I would be sitting here talking to you if I hadn't, because that's kind of kept my mood stable. But there are times when it's been unstable. It's been reasonably stable now for the last 3 years, apart from 1 or 2 blips, so that's been good. It is a long-term thing. It is about, I think it's quite hard for people to accept that. A lot of people in full recovery and they never have another episode, but some of us don't. some of us carry on knowing that there are certain situations that we don't cope well with, and situations I don't cope well with. And I know what sets off my patients. And so it's partly trying to manage those, but partly trying to acknowledge what I need. One of my greatest support's been my husband, but he's much better at picking up when my mood is going off than I am. He's extremely good at doing that. I do listen, I know that. But it's, I think with any kind of long-term problem, you have to find your ways of living with it. And it just becomes part of who you are.
And that comes back to the identity stuff again, you know, that we were talking about. Yeah. It's been really really powerful to listen to your story, and just lovely to talk with you about this. And I'm really kind of excited to have you as one of the contributors that we've got on the series here. It's been wonderful speaking to each and every person. And I really hope that people out there who are listening, who are mental health professionals or interested in training kind of into mental health, and have their own lived experience of mental health difficulties, will really find a narrative amongst the voices here to kind of step into, you know, that is helpful and real and true and positive and useful, you know, all of those things, whilst kind of honouring the pain of it as well. It's not easy. Is there anything else that you would like to say before we finish?
I think just picking up on a point we talked about before, people are always saying, you know, what kind of therapy should you have, and what kind of therapy is important. And I would say different things work at different times in your life. When I was younger, I needed to make sense of life, and dynamic psychotherapy was really helpful then. When I was older, I had to learn who I was and cope with other people. And I found CBT particularly helpful for that. And I do think it's really important that we don't, you know, I was really glad that I didn't have a therapist who kind of insisted, well, I'm going to offer this and this is going to help you. I had what's right for me at the right time, you know, and that was just really important. And when I was younger, I was busy trying to sort out problems in relationships and who I was. When I was older, I was still trying to do that, but CBT just helped. You know, the first time I met a psychologist who understood that my problem with ruminations was just amazing, you know, because he just understood those things. And so
sorry,
for
I
me,
didn't quite hear that. Was that you met a psychologist? Psychologist, yeah.
It was a psychologist who understood much more about the sort of ins and outs of how I thought and how I ticked over. So I think for me, it was really about trying to find people helped me to find what was right for me. And that was, I guess, a guiding principle of my work, that I tried to help people find what was right for them, rather than being sure that I knew what was right for them. And that was going to be what I did, you know. So psychology, psychotherapy, psychiatry, medication, things like how to spend your time and what your passions are, all of those things for me were very important. Your life, it's that whole mix, and I think we can get far too caught up in battles over what's on. It's actually a complete mixture, and people may need different things at different points in their life.
Mm-hmm. And do you think that your own lived experience has had an impact on that view of yours, or what's influenced you most?
When I was younger, I was very, very interested in psychotherapy. When I was a medical student, I was really interested in biological aspects of psychiatry because I studied work, and I was fascinated by that. And then when I was younger, I wanted to be a psychotherapist. At that time, I was really into feminism and feminist psychotherapy. And then when I've worked in certain areas of the north of England, like Salford, you can't help but be interested in social aspects. You're working with people who are struggling against the system. I worked a lot with women, and women who hold the world together and in deprived communities. So I've everything I've experienced as I've learned something else. All of those are important. My own family has a history of mental illness, so I think there's a biological factor there. I don't think I've ever been able to. I think I've always acknowledged that. But it's all the places I've worked have been mostly fairly deprived areas, so I've really learned a lot about the interaction between deprivation and mental health. But I've also learned a lot about the situation that women face in mental health as well. When I was younger, I did spend a while working with young women with eating disorders, because there was no one else in the area where I worked who was prepared to see women with eating disorders. So I became the sort of default consultant, and that was one of the other things that I guess fostered my interest in feminism and mental health, and the part played by, the image of women. So all of those, I think, for me, it's been always about learning from the situation I've been in. And I think that's probably reflected in my writing, that I don't write about one thing. I write about all sorts of different things. And that's why I think it's just so important to sit down with someone and find out what really matters to them. I was really fortunate in my therapists. I think they all did that. All bar one, who was the only one I saw privately, and I didn't get on with him at all. But I think he had a very fixed view of what my therapy should be. But everyone else I was fortunate enough to see on the NHS.
Fantastic. It's a very individual, multifaceted journey for each of us through life, isn't it? And how we meet people, our own experiences, how we meet people are coming through their journeys. And I was just thinking again about what you were saying about, we may have experienced mental health difficulties, but even within that, there are so many different possibilities about how those came about and why. And I think when we get down to the individual level, that's all you can do is meet people where they are, really.
Yes, and I should probably say that one of my therapists was working privately but refused to charge me because he said I should treat a fellow, I'm treating you as a fellow professional. And I thought that was incredibly generous.
Wow,
and,
yes.
But I think that's something that, sometimes people do. And because I think sometimes we need care from other people as well. And it's quite hard for us who work at the front line.
Thank you so much. And I just hope we keep in touch, and the very best with the writing of your second book. And I hope it goes well for you.
Thank you.
All right.
Thank you.
Thank you.
And thank you for asking me to be involved.
Oh, pleasure. Thank you for coming.